program. I have been with REACH for, it'll be 5 years in March. So I supervise a team that is comprised of our REACH clinical coordinators and our mobile support counselors, and we'll talk about both of those roles today. So I'm really happy to be here and keep this as informal as we can. We want it to be conversational. Ask us questions, ask us hypotheticals. We're happy to answer anything you send our way.
Yeah, thank you so much, Shelly. And Shelly is also my supervisor, but my name is Kate DeRosa. I am a mobile support counselor with the REACH program. I've been working with REACH for about a year now. I was a former special educator for 5 years, and I did work in Prince William County. If you were here before, you heard I worked at Freedom and I worked at Potomac High School. And now I'm working in a clinical capacity with the REACH program. And I'm actually an in-home provider. So that's part of my role. And like Shelly said, we'll talk more about that. I do see that I see Jan and Julia have their hands raised. If you guys don't mind lowering your hand unless you have a question right now, that way it's a little bit easier for us to see on the screen. Just give you a second to do that. Awesome, thank you. And in the chat, I'm curious, you can put a Y or an N, yes or no. Have you heard of the REACH program before? I kind of just want to get an idea of if people have heard of us. Okay, awesome. Thank you, Norman. Yep, awesome. All right, so you guys have heard about us before. Okay, good. Good. No, all right. Good, so we have, it seems like a majority of people have heard of us, but maybe you're not clear on all the services, but then some people have heard of us or have not.
That is wonderful to hear, Jennifer. Thank you for sharing that.
Wow, that is awesome. All right, well, I'm going to dive right into our presentation, but like Shelly said, we're going to be monitoring the chat. So if you have questions as we go along, we'd love to answer them because we really want to tailor it, especially since a lot of people know about this service. If you do want to throw give us an example or something, a case that you might know of, that's fine, but we just ask that you don't say names or anything like that, just to keep privacy. But yeah, we're going to get started. All right. This would be a good time to quiz the people who did know about REACH and ask them if they knew what REACH stands for. But REACH stands for the Regional Education Assessment Crisis Service Habilitation, and we are the Virginia REACH Northern program because we service Northern Virginia. Here are some of the faces of some of the people that could potentially have benefited or do benefit from REACH services. We are part of a bigger company called Easter Seals UCP, which I think probably some people have heard of because of their award-winning and fantastic summer camps that they have for people with intellectual and developmental disabilities. However, our program is part of Easter Seals, and it focuses on the crisis aspect of potentially having an intellectual disability or developmental disability. So when we get right down to it, we service both children and adults, persons with developmental disabilities, including intellectual disabilities. So we usually say a person with an ID or a DD diagnosis, or what is it for extended POP? We say
borderline intellectual functioning.
Yes. Yep. Or a assumed or probably, like a probable diagnosis. Yep. Who are also having maybe a co-occurring mental health illness or a behavioral disorder, who are at risk for a crisis event or in the midst of a crisis. We also talk about crisis events as being transitions as well. So if there's a big transition coming up, maybe the graduating from high school after the post-secondary 4 years and going into maybe like a group living situation or into supported employment, that can also be a transition that someone may experience some kind of crisis with, and that would be a person that we could support as well. And we also work with support systems surrounding individuals receiving services from REACH. So we work with everybody from a medical team, like a psychiatrist, all the way to parents or companions or caregivers, attendants, respite providers, siblings, anybody who would be supporting a person during a crisis. And can you see the chat, Shelly, because while I'm presenting?
Yep.
Okay.
I can.
All right. So why REACH? why would a person choose reach? Because, I think typically when someone's experiencing a crisis, we probably might think about calling 911 first. So why would we take that extra step to call not 911, but a substantially longer number? What's our advantage over 911? Because there's 4 big areas that we can do services in, including education, assessment, crisis services, and habilitation. So when we talk about kind of in my role as a mobile support counselor, I do 2 of these things, which is educating. So I work with family systems. I'm in the home or at the group home, wherever the person's disposition is. And I work about educating, just kind of getting information about autism, or getting information about a mental illness, or giving information and trainings on how to respond to a crisis. While I'm working in home as a mobile support counselor. And then I also am providing crisis services. So I'm not part of the on-call 24-hour, 24/7 crisis team, but I do provide crisis services. That's part of my title as a mobile support crisis counselor. So I'm in the home for up to 4 times over a span of 2 weeks for up to 2 hours a session, educating, training, observing, and overall just trying to get more information for a person's crisis education prevention plan, which is kind of the permanent product that we produce as Reach and are able to share with, like I said, all those multi-tiered systems like the medical teams, clinical teams, educational teams. We're able to support individuals by getting documentation out to everybody and all the services that they could benefit from that. And then Shelley, do you want to talk about the assessing and the habilitation portion?
Sure. So one of the biggest services that Reach provides is access to our 24/7 crisis line. I did put it in the chat earlier, and we'll make sure that that you all have it before we end today. We have an 800 number that is manned by an on-call crisis team 24 hours a day, 7 days a week, holidays, weekends, you name it. So we are available to assess crisis situations at any time. Sometimes we're able to do that over the phone. If not, and if it's an escalating situation, we're able to respond out in person. So a lot of times we do work in collaboration with calling 911 if there's imminent risk, but a lot of times we're able to come out, assess the situation, determine whether a need for a higher level of care is present at that time, or we're able to safety plan and de-escalate the situation on our own, with the goal of keeping the person in their home environment, out of the hospital, and out of interaction with law enforcement as much as possible. So that's part of our assessment. Also, when somebody is connected with Reach, you're assigned to a Reach clinical coordinator, which is essentially your Reach case manager. And that person is always providing ongoing assessment of the person's functioning, of their current mental health status, also of their environment, where we can make recommendations for possible changes to the environment that could help the person to maintain stability, providing that education piece as well, as Kate said, to the environment. We also keep an eye on the medical issues that a person might be experiencing that could also contribute to mental health crisis and provide feedback about that. We also are providing coaching and mentoring to the person's support system. That can be through the assigned clinical coordinator, case manager, or as Kate's role is, the additional level of support that we provide with mobile support crisis counseling. The counselor can actually provide that coaching and mentoring to a person's group home staff, family, whoever is going to be that ongoing support for that person. We're providing that coaching and de-escalation strategies, coping skill strategies, and again, making recommendations for environmental changes as needed. We want to make sure that we're teaching the effective coping skills, distress tolerance, really fostering independence based on the person's interests and their strengths. And ultimately, the goal is to strengthen the person's long-term system so that they feel confident and able to support the individual without the need of an additional crisis support.
Yeah, exactly.
So that's a lot, but that's us in a nutshell.
Yeah, that's exactly. So we want to take a second. We have more in the presentation, but if there's any questions about anything we just covered, I want to make sure that we look at that now. And I can just pull it up really quick because I see 2 things.
Will you send these slides out so we can share with participants?
Sure.
Okay. Thank you.
Yeah, no need to take notes. We got this.
Unfortunately, there will be a quiz though at the end. So.
Yes. Pass or fail.
All right. So we are going to talk about the REACH coordinator. So if you're familiar with the way that the Community Services Board has coordinators, they're kind of known as support coordinators or CSB coordinators. So in our role with our REACH coordinators, they're actually clinical coordinators, because remember, what we're doing is clinical work. And so this is kind of the Venn diagram of all the different things that a REACH clinical coordinator can help with. So right at the base of it, kind of like the bread and butter of what we do, is the crisis assessing, which if you call, I would say, I think almost all of the people that do the on-call who man the phones are also REACH clinical coordinators. Not all of them, but for the most part, most of them are. So that's kind of good, because if you call and you're with that's your clinical coordinator, then you already have rapport with them. And so what they can do is they can respond out or potentially assess over the phone or via telehealth if someone is experiencing a crisis that requires an assessment. So those assessments can take place anywhere from the home setting all the way to like I guess an involuntary hospitalization, or like through the TDO or ECO process. They can also do recommending intervention. So that might be when they introduce the recommendation for a planned stay at one of our therapeutic homes, which we do have 3 therapeutic homes, one specifically for youth crisis therapeutic home, and we also have an adult crisis therapeutic home. One is in the adult home is in Woodbridge, very, very close to Hilton High School, actually. And then our youth home is in Culpeper, because we do share it with another region. And we're going to talk more about the home, so don't worry about that. Or another intervention that they clinical coordinator could recommend would be services like mine with mobile supports. And so that's when I would go in, I would build rapport with an individual, do observations in whatever setting they're in, and kind of see where there might be some things to improve, what already is going really well. And then I can also provide resources, visuals, and those kinds of things as well. And then a step up from that, we have consulting and linking. So one of the things that I have been able to do is helping with IEP process, supporting individuals with their IEP process. Some of the things that I have seen before is REACH and calling the crisis line is a part of people's behavior intervention plans. And so if that is the case, of course, we would want to have representation at a BIP meeting for that, just to make sure that everyone understands what the program is and what that might look like for a person to call the crisis line during school, which we highly encourage, especially if someone is open to our services, because, we want to have that generalization of that. Of calling the crisis line. We want people to understand that they have that access 24 hours a day. Another thing we might link with is if someone isn't supported by the Community Services Board yet, that would be a program that we would link people with, especially youth. I think we have a program right now where we're really trying to fast track youth in need of links to the CSB. So that's another link that we might do. We may also link with group homes. We may also link with long-term care providers, psychiatry. We can companion services, respite services, transportation services. We could really link and try to get some information to people as best as we can. And then coordinating with communication. So we work with a bunch of different systems, like we said, the medical teams, clinical teams, school teams. We can kind of communicate with all of these systems as long as we have the release of information to do that, so that everybody is on the same page. School's not saying, well, why aren't we getting this service? Why isn't that available to us? It is. It's available to everybody all the time. Anything I missed about the coordinator's role? Shelley?
No. The communication piece, I think, is maybe part of our program overall that I don't think it's emphasized enough. I think especially when individuals have really strong teams and already have a lot of supports in place, sometimes you just need an outside person to come in, bring everybody to the table and say, this is what we're going to do. let's everybody get on the same page, and we come up with kind of an action plan, for lack of a better term. And sometimes just having that single person that can be maybe the reach coordinator come in and make sure everybody's on the same page, in agreement with what the plan is moving forward. That's something we're very comfortable doing, and I think it's a great benefit sometimes.
Yeah. All right. So we kind of did talk about this before, but this is just another reiteration of what Reach can provide. So there is the crisis line, which is, we have people on call 24 hours a day, 7 days a week, 365 days of the year. And they can offer face-to-face responses, de-escalation via phone as well, which is actually a really strong tool. So not every call that we get are we going to need to respond face-to-face. There may be the ability to de-escalate over the phone, which, you know, preserves that person's privacy, also preserves the system to stay intact and not feel like every single time that there's a crisis, someone else needs to get involved. Because sometimes it's better in a crisis to keep numbers small, try to deal with it as best that we can. So and we can also do those assessments when we do responses as well. There's also the community-based mobile crisis services. So mobile supports is a part of this as well. That also the development of the Crisis Education and Prevention Plan, the CEPP. And then also we have something called the Crisis Stabilization Plan, CSP. Yes, CSP. That is something that I would use as a mobile support counselor, or if you were at one of the therapeutic homes, that kind of illustrate your goals and the objectives that you're working on. It's sort of like a little mini IEP for your services. So whether you're getting mobile support services and you're working on developing 3 new coping skills, or you're at a therapeutic home working on remaining calm during a transition, those would be examples of things you might work on in your CSP. And then last but not least, we also provide the crisis therapeutic homes. And so we do have an adult and a youth home. They provide residential crisis stabilization. They are not long-term though. All of our services are short-term. So for mobile supports, it's 2 weeks. For a stay at the crisis therapeutic home, it is 2 weeks as well, right?
Yeah, it can be up to 2 weeks. And at the end of that time, we would have to reassess to see if the person still met criteria for continued stay. Because what I want to reiterate is that our homes are not meant for respite. There actually are certain criteria that have to be met per Medicaid requirements, per licensing requirements, that the person has to meet the criteria for continued stay. So if someone is admitted, we usually start with 2 weeks, have team meetings throughout to assess their progress and go from there.
Yep. And then our youth home is actually a little bit shorter than that. It's a 10-day stay because we're in compliance with how much a student can miss of, you know, part of their education. Let's say they did a planned stay during school. You know, we'd want to stay within that so that they could still receive services. We also can do step downs. So that could be diversions from hospitals, jail, training centers, some of the things that, you know, our population may not really want to be in any of those settings and may need something that's more of a therapeutic environment rather than hospital or jail. We also can do preventative stays. So this is something we especially do with our youth home. Is we know that this time of year, you know, hashtag no school November is really hard because you don't even have, you know, you have 1 full week of school. Going into that, we might say, okay, this is going to be a difficult month because it's going to be start and stop. So maybe at the end of the month, we'll do like 4 days planned stay at the YCTH, more just for that preventative measure, or maybe right before winter break when a person's going to be home for a while, and just helping them kind of build back up those skills for resiliency and distress tolerance. All right, so we're gonna go to the next slide. And this is all about our 24/7 crisis response. So when you call the crisis line, so the bottom there's crisis response and assessment. Then there can be mobile crisis services. So that's when we would develop a crisis stabilization plan, because maybe we are recommending a planned stay at one of our therapeutic homes, or maybe mobile supports. And then it kind of at the top is the home admission. Did you want to talk at all about the admission criteria for the homes? Okay.
Wasn't sure if you had a slide specifically for that, but yeah, I'll jump in here, and then if we have a slide, we'll go with it.
Mhm.
So there's really two different types of stays at our home, guys. There's a planned stay, which Kate's already touched on, and then there's what's called an emergency admission. So let's talk about the emergency admission. This is for adult or youth. What that means is we've been contacted via our crisis line, but the 24/7 crisis line. The person is experiencing a mental health crisis in the moment. We've responded, we've assessed. We determined that they don't necessarily meet criteria for hospitalization, but they definitely would benefit from some kind of a higher level intervention and removing them from their current environment. In that situation, we would consider an emergency admission to our crisis home. What that would look like is the individual would have to be medically screened right then and there. So either going to the local emergency room, or sometimes even an urgent care can help us with that, especially if we call ahead and explain the process of what we're doing. But typically it's the emergency room. Would have to be medically screened. We do have a medical screening form that has to be completed by a healthcare provider. We would also have to get medication orders written up and signed by a doctor. Sometimes the emergency room is happy to do that for us. Usually we're able to advocate through our coordinator to get all of that completed for the emergency admission. And right now we do require a negative COVID test. After that's all cleared and signed off on by our nurse, we do have 24/7 nursing that helps us with all this. So admissions can happen at 2 a.m. Then the person would be cleared for admission to our home. So an emergency admission is through an emergency crisis response that occurred by contacting our crisis line. And then, as Kate said, there is a planned admission. So for instance, I have a young man on my team right now who historically, November is a really hard month for him. He does well for most of the year, but leading up to November, he even gets in his head saying, I know November is going to be bad. So we started planning in October. We started planning in October for him to come and spend 2 weeks with us before Thanksgiving so that we could try to help keep him stable leading up into the holidays so that he can enjoy it with his family. That is a perfectly acceptable plan to stay, and is working out so far. So that's just an example of what a planned stay is. And then the step down. So I guess there is three different types of admissions. Step down is a great way for somebody who's maybe spent some time in the hospital or jail or even a residential program or training center. They can step down to us and spend 2 weeks with receiving continued stabilization services and therapeutic intervention before they're going straight back into the community. We do this a lot for folks who've been in the hospital and then are ultimately going to discharge to a group home. We bring them to us for an additional 2 weeks to provide that kind of in between to get them comfortable and moving back into the community. So that's a great resource as well, and is usually pretty successful to give, instead of just having that all happen at once, to kind of ease back into that transition. So are there any questions about the admissions? All admissions, whether it's planned, an emergency, or a step down, everybody has to have a medical screening. We do provide the forms, have to receive a medical screening, and we also have to have medication orders written and completed by the doctor, along with a negative COVID test. Those are required for all admissions, youth and adult.
Even if someone is vaccinated?
Even if someone's vaccinated, we still have to have a negative COVID test, and that has to occur within 5 days of the admission date.
Yep.
Okay, and while you're at while an individual is at the crisis home, they're receiving, if a person, can they go to one of their, they sure can. They sure can. That is not an exclusionary thing. Now, obviously, we would put in a safety plan for that individual. It might include increased staffing, at least for the first, 24 to 48 hours. We might put different restrictions in the home as far as access to certain items, keeping them on line of sight, or additional checks. But yes, that's actually happens quite often. We get a call from emergency services or the ER that somebody has come in with suicidal ideation, and we're able to respond out and assess them one-on-one and determine if we can bring them in and support them. So yeah, Kristen, that can happen.
Yep. All right. So then when we talk about our mobile community supports, we are talking about the foundation of assessing an individual and their interactions within the environment that they're, that they're living in or is most familiar to them. Because assessing somebody at the hospital setting versus their home setting is very different, looks very different. Then we may develop a crisis stabilization plan. We implement the plan with the individual and their support providers, and then we do prevention through follow-up or continuing intervention. So I think people are open with a clinical coordinator for 3 months, right, Shelley?
Typically.
Yeah. And then if there's a need to extend that, then of course we will. But, part of what our program is very short term. So we try to help get through the crisis, develop the crisis education prevention plan. And then our goal is to discharge you from our program as quickly as it is for you, as works for you. And a big key to the mobile community supports, especially from the mobile supports perspective, is the training and the involvement of a person's support system within our sessions. So I think there is a little bit of misinformation about mobile supports, potentially, that mobile supports is like respite care, companion services, ABA services. We're none of those things. We are coming in to really talk with individuals and work with their system to try to facilitate a plan that works for which is realistic and actually works for them in the home setting. And so especially for example, since we're talking to a school program, most are going to be youth. You need to be in the home with your children if they're going to be receiving services with us. We are not meant to supervise or be in any position like that. So while mobile supports is really awesome, it really does depend on everybody being involved in all of the sessions, because they are very short term. So we want to get as much as we can out of those sessions.
Yeah, we're there not just to support the individual, but to provide the training to the people who are going to be working, whether that's parent, group home staff, whomever, training them on everything that we're also training the individual on, so that they feel secure and ready to independently support them when we do ultimately step away.
Yeah. And I would say one of the biggest goals for mobile supports is to build capacity for those systems, so that if you're supporting a person going through a crisis, you feel like you have the skills and all the tools to do that. And it's not like a Band-Aid getting ripped off when your mobile support counselor leaves. That's not what we want. So there is a portion of this dedicated to the therapeutic homes, but I think we've talked about all of these. So for the youth home, it's 15 days, 30 days of residential.
And again, this has to be reassessed after 2 weeks. If somebody does meet requirements for continued care, we can extend, but we always start with 2 weeks.
Yep. And the youth home actually starts at 10 days. So
yeah. And can go up to 15 if they meet continued requirement. We do have to cap it at 15 though, even if they meet the continued care criteria at 10 days due to licensing. They can't stay longer than 15 days.
Yep. Our homes offer a high degree of structure, and we do have direct support personnel that work there 24 hours a day, and our individuals are supervised depending on their level of supervision needed. But there are people there all day, every day at all of these homes, helping prepare meals, maintaining the cleanliness of the home, supporting the individuals through crisis, or even just if they are just feeling down that day. Maybe it's not just like a crisis, but they're just not feeling themselves. That would be something our direct support people would support us with.
How many adults live in the home? Our adult home is licensed to accept up to 6 individuals at a time. Everybody has their own bedroom.
So it can be mixed genders.
It is mixed gender, but everybody does have their own bedroom. We can handle licensed up to 6 at a time. Now, sometimes we do have to reduce our capacity if we have individuals who require enhanced staffing. So if we have some folks that require 1-to-1 staff, we may be only, accept 5 folks at a time, but we are licensed for up to 6.
Yep.
Yeah. Same thing for the youth, actually. We're licensed for up to 6, but again, depending on the acuity of the individuals there or enhanced staffing, we may have to drop it down to 4 or 5, but licensed for up to 6. And again, at the youth home, mixed gender, everybody has their own room.
And one question we do get is are the homes accessible for people with physical disabilities? Absolutely.
Yep.
So we've supported individuals at all the homes who needed help with ADL, so activities of daily living, things like if they are not using a toilet, that's something that we can assist with. We have accessible showers and things like that, and our staff are all trained for supporting anyone. Hopefully that answered the question in the chat. All right, so our next portion is about prevention stays. And so Shelley already did a really great job talking about this, but you know, one of the great things about the homes are preventions or step downs or diversions from other places that, you know, right now, like the bed capacities at any of the milieus are not good. They're searching for beds constantly for people. So if we can be an extra bed, that's great. And that's something that we would want people who can get benefit from our services to do, or to at least, you know, very seriously consider our option. And what's great about our program is, again, for the therapeutic home, someone still does need to have the ID or DD diagnosis to get access. So that may also be a big advantage to our program and to our home, is that everybody, all the people that work with our individuals are all trained for ID, DD. They're passionate about the work that they do. And so you would be in a home with other people who also meet that criteria. So that may just be a better environment for some of our people who benefit from the home. All right, and then working with us, you know, we work with providers and families. We've talked about working with emergency services, and then also psychiatric hospitals. So with emergency services, we actually do training for police officers who are seeking the crisis intervention trained status, so CIT training. We provide training for that. And so that would be, you know, one of the things that we do recommend, or on call will recommend, is if you do feel like the response that you need is from a police officer, that you actually request a police officer with the CIT training, because they've gone through training with us, they've gone through other training, extensive training actually, and how to de-escalate situations for people with intellectual and developmental disabilities. And then, do you want to talk about the TDO process at all? Okay.
So the TDO process is something that we're very well versed in. We obviously like to avoid hospitalization at all in every situation that we can. However, something that does happen and we're part of is being contacted through the crisis line when an individual has is receiving or is experiencing a current mental health crisis. We do tend to collaborate with law enforcement and emergency services for the TDO process. That could mean that emergency services has also done their assessment of the individual and have determined that they are not safe to return to the community at that time. So they would be placed under a temporary detainment order, and at that point they would be hospitalized. During that process, we are asked to co-assess to make sure that we are also in agreement with the TDO determination. The reason that REACH is contacted for that is because we are the experts for ID/DD. Not everybody in the field in emergency services has received the same level of training in ID and DD that we have. And as we all know, someone who has an intellectual or developmental disability, their behavior and mental health symptoms can be presented in a different way than somebody who does not have that disability. So we're there to make sure that the clinician at emergency services is assessing them as a person with ID or DD should be assessed. That being said, we can help support individuals who are non-speaking, who communicate without words, and we can make sure that they're being properly assessed and that the hospital determination is actually appropriate for that person. If somebody is TDO'd, meaning they are going to be hospitalized, we have a hospital liaison who maintains constant contact with hospital social workers throughout our region for children and adults, participates in their team meetings, that's in the third column here, and make sure that we have input on what the person's discharge plan should look like when they return back to the community from the hospital. At that point, we may recommend a step down, as we talked about, to bring the person to one of our crisis homes for continued stabilization before they return home. The hospital liaison makes sure that the person who's in the hospital is connected with a REACH coordinator if they hadn't already previously been connected before the hospitalization. And we make sure that we stay involved in the process to get the person transitioned back home smoothly. So if there's any questions about that, let me know.
All right. All right, so we're just at the end of our presentation formally with the PowerPoint. So like we said, we are the REACH Region 2, which means that there's other regions that have the REACH program. So our number is the 855-897-8278. And when you call, you'll be prompted to press a number for your community services board. And we support the Loudoun CSB, Prince William CSBs, and the Fairfax County CSBs, as well as Arlington and
Alexandria. Yep.
Yep. But we say like the big three, and then Arlington and Alexandria are in there. So all of Northern Virginia is what we support. And then if you guys do have questions, here's our director's information leave for the northern portion. All right, but now I really want to get into questions. So I know that was a lot, but what questions might you have about the REACH program still?
Before we jump into questions, I just want to talk a minute about our referral process. How can you get connected? Because there wasn't a slide about that. I'm going to make sure it gets added for that.
Yeah.
So how do you get connected to us? It's through our crisis line. That 855 number that was on that last slide, that is our, we have a single entry point of contact for everybody to get connected to the program. So like Kate said, when you call our crisis line, you will be prompted to select a number if you are actually experiencing a current crisis and need assistance from a coordinator, or I think you press 2 if you want to place a referral. So if you want to place a referral for anybody, call our crisis line. You'll either talk to our intake coordinator, who's Rachel Campbell, she's wonderful, or you'll get one of our clinical coordinators. When you are placing the referral, come prepared with some certain information about the individual. We're going to need to know their diagnosis, demographic information, contact information. We will ask for any providers you currently have in place, whether it's a CSB support coordinator, psychiatrist, behavior specialist. We will ask for their contact information as well. We do ask for their hospitalization history. That can be approximate, you know, we don't necessarily need a specific dates or anything like that. And we definitely need insurance information. Now, REACH is completely, we're nonprofit. It is completely free of charge for anybody who comes with us. The payment is never a barrier. However, if somebody does have Medicaid or has a Medicaid waiver, we are able to bill that for our crisis services. If you have no insurance or private insurance, it's not a barrier. We don't bill at all. So we will ask for insurance information at the time of referral. And then we will ask for some supporting documentation. So a copy of an individual's psychological evaluation, a school evaluation, or a copy of their IEP if they are receiving services under the autism label, because we have to confirm that somebody actually does qualify for our program. For children, you have to have a confirmed ID or DD diagnosis. For adults, to be open to our entire program, meaning you can access our homes, access mobile supports, and receive a fully completed crisis plan, you do have to have a confirmed ID or DD diagnosis. For adults, if there is a suspected diagnosis of autism, intellectual disability, developmental disability, or they have borderline intellectual disability, we can open them, only adults, as an expanded population client. What that means is they get kind of an abbreviated program where they're only open for 45 days. They can access mobile support, and we can help with system linkages to make sure they have long-term support in place. Under the expanded population, though, they cannot access our crisis home. Those have to be, anybody at our crisis home has to have a confirmed ID or DD diagnosis. That's correct, yes. 18 plus is adult for our verbiage. So that's how you would place a referral. Just call our crisis line. We'll walk you through it, get all the information that we need. Once we have the supporting documentation to confirm that somebody qualifies, that tends to be the biggest delay in getting someone assigned. So if you have that ready when you call and you're able to email it to us or fax it, that's going to expedite everything. Once we have that confirmation, your case will be assigned within 24 business hours to a coordinator, and then that coordinator has an additional 24 business hours to make initial contact with you and schedule your intake. Intake assessments tend to be about an hour and a half, and we try to do that within 10 days of getting your case assigned. Gathering background information, it's a great way for the coordinator to get a full picture of what's going on, what's worked, what hasn't worked. And then your coordinator starts building your crisis plan. We have a very complex. I mean, it's filled with lots of information, our crisis plan, but we try to make it, we have tables that are very accessible, and we talk about stages of crisis and interventions to use at each stage. And that is what your coordinator works on. The coordinator also determines whether they feel mobile support or possibly an admission to the crisis home would be beneficial. And that's obviously discussed with the entire team and have input on whether they feel that that's something we want to move forward with. Will Medicaid pay for current support services? Sorry, I'm missing mental health skill building. Yes, because we are a crisis service, it's not considered dual billing, Jennifer. So even if somebody is already in mental health skill building, ABA, et cetera, Medicaid will still pay for us additionally. Yes, it's not considered double billing.
Yep. And that's a good question about billing, because I know that some people may think that they can't get the services because they think that it costs money, but you don't have to have you don't have to have Medicaid, you don't have to have waiver. Well, I would say, what is it, like 90% of what we do is non-billable anyway, like we're not billing for that kind of time. Another question that I've seen come up, or people are hesitant to contact REACH, is about their immigration status, and that doesn't matter. So they need to live here in Virginia in whatever capacity that they do and have a DD or ID diagnosis. Or it can come from the IEP process too. So I think Shelly mentioned, like, you know, an IEP with autism diagnosis, you could have that, you could have ID on there, you could have CP under OHI. So anything that would be under the category of developmental or intellectual disability.
Yes, and just as Kate said, the person does have to live in Virginia. We've had some folks that live across the border in Maryland or West Virginia. You do have to be living in Virginia to receive our services. For us, we are the Northern Region, Region 2. So if you're in one of the 5 localities that we support, you're with us. If the child or the adult ends up moving to another area of the state, we transfer the case to that region. So there's continuity of care, reaches through the entire state. So that's just something to keep in mind. Have you worked with we absolutely have worked with young adults with fetal alcohol syndrome. That is a qualifying diagnosis for us.
Yep, we're very familiar with this diagnosis. Something we do see. Trying to give people the ability to
ask some questions.
Yeah. And one thing that's been unique since I joined, because my background is, so I have a master's in education and special education, and I have a Virginia teaching license in adapted curriculum, is I've been able to work with IEP teams per family's request or per individual's request, of course, working with them, reviewing IEPs and looking at where IEPs services may help a person with crisis, or maybe just getting reached somewhere in their IEP or through the FBA BIP process. So that's been another service that we've had a lot of success with, and parents feel very empowered with knowing that they have kind of that as well. We also have a BCBA that we can do as well. So we have a behavior analyst who works a lot with our homes. And since we're not a strict ABA service or anything like that, we're very much whatever intervention works for a specific person. It's very personalized, but we do have a BCBA who can help us with some of those traditional ABA practices or interventions that may help support someone. Trying to think. We also have Dr. Shear.
Dr. Shear is our medical director. He has his own IDDD clinic in Fairfax with the Community Service Board, but he is our medical director. Typically with his involvement, he doesn't provide medication or anything like that for people that are just open to the REACH program. However, if somebody is at one of our crisis therapeutic homes, he does do consults. He can prescribe medication. He's one of my favorite people too.
Awesome.
Yeah, he's great. But he at the homes, he does do consultation and provide medication management to folks at the homes if needed. However, there is a referral program for Dr. Shear's clinic that can be accessed for anybody who's in REACH, who does, maybe needs to be connected with a psychiatrist. If somebody has a support coordinator, we do ask that they complete the referral, but if they don't have a support coordinator, we can do the referral for his clinic. During the holidays, can they come home for the day? Yes, they can. We have we're allowed to do, obviously case by case basis, making sure it's safe and appropriate for that individual. But yes, you can ask for a day pass. Yes.
Our program, and I don't know if we said this specifically, but our program is 100% voluntary.
Yes.
So if a person, even if their family might have guardianship of them, if a person is voicing strongly that they don't want to be somewhere, they would not like to be at the CTH, we try to work with them to say, hey, this might support you. But at the end of the day, we are human rights activists and we are also advocates. And so if someone does not want to be there, it is not a forced program. It is a completely voluntary program.
Yes, and if somebody does express that they want to leave, we do try to sit and counsel and coach them to determine why they don't want to be there and see if we can make, accommodations to make sure that they're getting the most out of it. But at the end of the day, we are a voluntary program.
Yep.
Yeah.
Any other questions? These are good. Oh, wow.
That's a good one. Okay. 2-day program. Does mobile short come out right away? Okay, so your question would be essentially, would you get immediate support right away? Through the crisis line, if there was a crisis occurring, you would get immediate support from the on-call coordinator. Yes. How do we avoid a stay in the home? To avoid it, do you mean to avoid a stay at one of our crisis homes? Okay, if that's not appropriate, that's fine. Some people do not do well to be removed from their environment to one of our crisis homes. In that case, mobile support might be a better option, having someone come to you into your home. Now, there is a little bit of a wait list for mobile support right now. We do try to get the turnaround as quickly as possible, but if somebody is at high risk for being hospitalized, at high risk for losing their current community placement, mobile support is a much quicker turnaround. We do list them as a high priority case. The homes aren't for everybody. Having somebody removed from their environment can actually be more triggering for some individuals who are already in crisis. So that's really up to the determination of the individual and the people that know that person best. But for immediate support in any kind of a crisis situation, you're going to want to call that crisis line so we can have somebody dispatched out for immediate support. And that person can create a safety plan, create on the spot written safety plan, and even try to provide recommendations for system linkages in real time to try to help de-escalate and keep the person in their environment.
As well as do assessments based on suicidal ideation as well.
Correct, risk assessments.
Safety planning.
Yep.
Great question.
I hope that answered your question.
Me too. All right. One of the things
my dog just propped the door open, so I apologize.
One of the things I was going to say is if we're talking about the school setting, a school social worker may be a point of contact for families, definitely who maybe are seeing crisis at home and maybe not necessarily at school or maybe in both settings. School social workers, for the most part, they know who we are, so that may be a recommendation. But if you know about us, you can always call. That's the best thing to do. You don't have to go through anyone at the school. This is a separate thing with the school. We can just collaborate with the school. We have responded to schools in the past. I think I had said that before. So, if you could call the 24-hour crisis line and we can respond to schools if the clinician thinks that's appropriate. But yeah, working with school social workers or school counselors would be a good way to get the information distributed to parents, even special ed case managers or special education teachers. We're trying to kind of get this information out so that we can make sure that nobody is in a situation, especially going into the holidays, where they feel like they're just alone. That's like the last thing we want to happen, because we do exist.
What happens here? Kristen, would you be?
I think it's lack of information.
Yeah, I would say.
Yep. I think that
would be my biggest guess, especially if there's a qualifying diagnosis and things like that. Yeah, I can't specifically say why you wouldn't have been referred. I do think maybe lack of information is a big one. Hopefully we're trying to remedy that now to get our word out. But if you feel that you want to be connected with us and we would be a good support, please give us a call. We're happy to place that referral for you.
Yep. Or maybe it's a call to action for you now. If you're using social media, you can always post our information so that if, like, you know, I know that the friend groups within families, that's how word of mouth gets around too, is just saying, oh, we worked with the REACH program if you're experiencing this kind of crisis.
So your second part of that question was about the psychiatrists. I'm not sure that a lot of private psychiatrists in the area would know about us. The CSBs definitely do, and the psychiatrists that work through the CSBs definitely know about us.
Yeah.
You should have been told on the first visit. Absolutely.
Yeah, for sure. Yep. Yeah.
And just to put it out there too, as far as our crisis line, we don't just respond to homes or schools or hospitals. We've responded to the side of a highway when somebody was experiencing a crisis in their car with their parent. We've responded to grocery stores. We've responded to McDonald's. We've just responded to freeway or crosswalks. I mean, if you have a crisis and you're not safe and you need help, you call us. And if it's something where we do need to collaborate with 911 or law enforcement, we can help with that. But you know, don't think location is limited. We've been there and done it.
As long as it's loud in Fairfax,
As long as it's in those 5 catchment areas, you're in good shape. You can call us. And even if you were outside of our catchment area and you called us, we could direct you to the appropriate region for your current crisis to be addressed. But yeah.
Yep. So let's say you're on vacation in Virginia Beach and you have used our services before, and then your child or your adult child goes into crisis while you're at the beach. You know, their system functions in the same way as ours does with 24/7.
And even if you only had our number saved, you could call us and we would get you connected to the Virginia Beach region to make sure you got services.
And because this is part of Easter Seals, it's Virginia and North Carolina. So there are REACH programs across Virginia and across North Carolina.
Where the crisis home for REACH is located, this REACH is different from Easter. We are Easter Seals REACH.
Yep.
REACH is our program, but we are run, organized, owned, operated by Easter Seals.
Yep. And
so that's why our email addresses are Easter Seals email addresses.
Yep. Our youth home is in Culpeper. And our adult crisis therapeutic home is in Woodbridge, right across from Hilton High School, if you guys are familiar, because you're Prince William folk. Good question, though.
Yes. Yeah, Easter Seals is our umbrella company, but we, so it is the REACH, and Easter Seals REACH is the same thing, yeah.
Yeah.
Pop quiz. Any other questions? Oh, sorry, Kate.
I was going to say pop quiz. Anybody know what the UCP stands for at the end of Easter Seals? Write it in the chat if you do.
Well, it's United Cerebral Palsy. I didn't write it in. Yeah.
You win.
You win, Jan.
Brownie points for Jan.
Yep.
I worked with them for a long time when I first
Easter
came.
Seals is a great company.
Yes.
They are. They do a lot of good.
All right. Well, thank you all so much for coming. Okay.
Yeah.
Extremely helpful. Yay.
Hopefully we get some referrals from some folks in here that think this will be beneficial. We're happy to work with you. If you think of any questions later, you feel free to email us, or honestly, even if you just need more information later, you can get that through the crisis line too.
And just if you didn't see it in the chat, this is Jan Russell. I will be forwarding the slides and a link to this recording to everybody who had registered. So you will get copies to refresh your memory if you need to. Thank you everyone for coming.
Thank you guys so much. Happy holidays. Be safe. Take care of yourselves.
Thank you.
And I'm just going to keep it open for just a little bit, for just a second, so I can put the rest of our information. Thank you. Yeah. Thank you guys so much.
Okay. I will stop recording then. Thank you all.
Okay. Jan and Rhonda, do you want us to stay on or?
No, you're good.
All right. Awesome. Thank you, Shelley.